Let me introduce our three consultants who are very diverse and I think will bring an interesting perspective to this conversation. Malvie Scott is Senior Vice President for Partnership and Resource Development of the National Association of Community Health Centers. Dr. Scott's responsibilities include developing and managing relationships with foundations, pharmaceutical and medical supply companies, government agencies, health insurers, and other companies that result in increased funding, knowledge, management, support, products, and services for health centers, health center-controlled networks, primary care associations, and the National Association. Prior to this position, she served as NAC's Vice President for Programs and Planning. After receiving degrees from North Carolina A&T State University and the University of North Carolina at Chapel Hill, she was employed at Wake Health Services, a community health center in Raleigh, North Carolina, for 20 years, 17 of which as President and CEO. During the period she was a health center CEO, she was elected Secretary and Chairperson of NAC's Board of Directors. Gabrielle de la Guinière is Deputy Director for National Policy of the Legal Action Center. Gabrielle leads the Center's federal policy advocacy to expand and improve health responses to drug and alcohol addiction and to end discrimination against people with drug and alcohol addiction histories and criminal records. Located in the Center's Washington, D.C. office, she works to increase funding for drug and alcohol prevention, treatment, recovery, and research programming, to expand services for people with criminal records who are seeking to re-enter society, and to eliminate legal barriers faced by people with criminal records and drug addiction histories as they seek to obtain employment, welfare, student loans, and housing. Ms. de la Guinière also, Gabby also leads the federal, I know her terribly, Gabby and I work together a lot, so it seems strange to say her last name quite that way. Also leads the federal advocacy for the Center's national Helping Individuals with Criminal Records Re-Enter Through Employment, which is called HIRE, network. She joined the Legal Action Center in May of 2003 as a law student intern and became Deputy Director of National Policy in 2007. So you can see she has moved along. Linda Rosenberg is President and CEO of the National Council for Community Behavioral Health Care, now known as the National Council. Good. Linda is an expert in mental health policy and practice with over 30 years of experience in the design, financing, and management of psychiatric treatment and rehabilitation programs. Since 2004, she has been President and CEO of the National Council, a not-for-profit advocacy and educational association of more than 1,700 organizations that provide treatment and support services to 6 million adults and children with mental illnesses and addictions. Prior to joining the National Council, she was Senior Deputy Commissioner of the New York State Office of Mental Health, where she strengthened the voice of consumers and families in the policymaking process, promoted the adoption of evidence-based practices, including tripling New York's assertive community treatment capacity, and expanded children's community-based services. And now to my questions for the discussants. Let me start with Dr. Scott. How will community health centers meet the new demand for behavioral health services generated by this newly eligible population under the ACA? Do you anticipate community health centers to be the medical homes for this group?
Thank you. Let me say something briefly about what these animals are, these community health centers. There are some, they're private, not-for-profit organizations. There are some 1,200 of them in the country, and in every state, in every territory, and they represent both urban, rural, and frontier individuals. They provide essentially primary preventive care and access to other services in the community, either on-site or by referral. There are some 1,200, as I indicated, of these corporations, health centers, some 8,000 sites in the country. They treated in 2009 some 19 million patients and over 7 million visits. So there are a number of services that are provided through these organizations. And let me indicate, during the Bush administration, there was a commitment to double the size of this program. This program is 45 years old. That was done. The ACA, during the allocation of both an additional $11 billion in a trust fund, as well as the $2+ billion in routine appropriations, anticipates that there will be another doubling of the program to 40 million as opposed to 19, 20 million patients by 2014, or at least be prepared to do that. That growth is significant and will provide additional resources both for the current population and for additional population, including detainees. With regard to behavioral health, that has been offered to patients in a variety of fashions. As a health center director, as you indicated that I was, and as a reasonably small organization, there were no mental health professionals on site. It was a matter of doing it in a number of ways, and health centers have always had to look for what works best in their communities, given the resources that they have. In some instances, for large organizations, there were professionals on site. There were some instances in which professionals came in and served sessions at the health center to provide services. Some just doing training, technical assistance or whatever for existing primary care providers, and making some effort at encouraging other people to come into the system. Some of the services were provided by primary care providers on site, having gotten some TA training, et cetera, from private practitioners, behavioral health practitioners in the community. But let me tell you what the numbers look like in terms of where they are, because it's important to know how far we'll have to go to help meet the demand, because the resources are insufficient as they are for existing patient populations. In 2009, there were nearly 3,800, mental health, substance abuse providers in the system that were staff of the centers. This is out of 123,000 staff total. There will be the need to increase those numbers to make sure that we can provide the services to this population. Now, you would think I was on drugs if I told you I thought we could do that by 2014. It's not going to happen. What it will require is significant commitment to integrate, collaborate, as well as look at the long haul and see about training more people. There will be the need to do that. Health centers are prepared to do that. With regard to the question about whether health centers will meet the demand, they are prepared to help meet the demand. I would be remiss if I said, oh, of course, we'll meet all the demand that's there. Not happening. What will happen is that there will be a renewed emphasis on addressing the needs of this population and assuring that we work more closely with other providers in the community to do that. That's the only way it's going to happen. in the short term. And the long term, it means all the workforce issues you talked about this morning will be a part of that. I might say parenthetically that HRSA, the Health Resources and Services Administration, intends to put another $25 million to expand behavioral health resources in health centers that will help with this activity. With regard to medical home, health centers are absolutely prepared to treat patients as other patients are treated. That is a medical home. They are part of the community. As a matter of fact, many of the detainees that you're talking about are in the same census tracts, the same zip codes as existing patients. And by statute, as well as by social inclination, health centers will not treat them differently. They're committed to not doing that. And frankly, many health centers have provided care to individuals before. I have a bigger concern about the patient-centered medical care model, and it's more that we will treat it, and I say we collectively, as a project, as an initiative, as opposed to what is needed to transform the system. Is doable, and I think it will have a transformative effect on the system, but it has to be looked at over the long haul. And one of the hallmarks of doing that is not just whether it's accessible, whether it's patient-centered, whether people can get next-day appointments, whether any of those things, but whether the providers are accountable for the care that's provided. It's one thing to say, I had a visit yesterday. It's another thing to say, I made a difference and in this person's life, his or her family's life, or whatever. Health centers, in fact, are embracing the patient-centered medical care, medical home, as they have over a long period of time, providing such service in what we call enabling services as transportation, interpretation, some even doing case management around housing and other kinds of issues. So the answer is, no, health centers will not be the only entities that will meet the demand. Yes, they are absolutely prepared to work with other organizations in the community to make that happen and to look over the long haul to be sure that we, as we would expect other providers, are accountable and we can look out over the long haul and say that we made a difference. Thank you.
Thank you so much. Gabrielle, given that durable recovery is frequently a stop-and-start process, how does this change paradigm of treatment that under the ACA affect the location of service delivery? Or put another way, does Medicaid expansion favor treatment in the community versus institutional settings or other settings?
Sure. Thanks, Mady. It's good to be here with all of you. And my boss, Paul Samuels, is very apologetic. He wouldn't be here, but I'm happy to be with all of you. As others have said, we really think that the Affordable Care Act opens up a lot of potential for people to get better care and to have better access to care. And those of us working in the advocacy community to ensure that people with... Sure. Those of us in the advocacy community who are working to ensure that people with addiction and mental health treatment needs have good coverage and good access to all of the types of care that they need, we are confident that people with criminal records, criminal histories involved in the criminal justice system, we expect that those individuals will be able to really benefit from the new benefits and protections offered through the Affordable Care Act. A lot of work needs to be done, and a lot of work is ongoing now to educate people in all of our systems about the disease of addiction, about how addiction is a chronic disease, and about treatment, including medication-assisted treatment, and all the types of interventions that need to be available to help people get well and stay well, recovery supports to help people maintain their sobriety and maintain their recovery. a lot of work to be done at the federal level that we're all doing on the regulatory process here, also in the states. We know that there's a tremendous amount of work being done, again, to educate people about what's clinically needed care and for clinically needed lengths of time for care. With passage of the federal parity law, which requires large group plans, including Medicaid managed care plans, to provide mental health and addiction benefits in no more restrictive way than medical and surgical benefits, this again represents, I think, a greater understanding of the chronicity of addiction and the need to ensure that people with physical and mental illnesses have, again, good coverage and access to all of the types of care that they need. I think with the Medicaid expansions in particular, we know, again, this is going to reach millions of childless adults who have not had coverage for care and have not had good access to care, and that certainly this will hopefully incentivize people to receive care through the community-based care system and ensure that they have what they need. The requirement for this new expansion population through Medicaid to have a certain type of benefits. We know there are certain essential benefits that are required, which again include substance use disorder benefit and a benefit for mental health. Again, that will really expand, and others mentioned earlier that through Medicaid with addiction benefits in particular, it varies tremendously around the country. Depending on which state you're in, the coverage for addiction treatment. But again, now with this new requirement for the newly eligible childless adults and parents to receive an addiction treatment benefit, again, we really think that more people will be able to get care. As others mentioned, also the suspension versus termination policies, other mechanisms and policies to determine eligibility and enrollment, I think they're going to be very important as we all move forward. And I'll stop there. Okay. Thanks.
Let me remind you, before I move on to Linda, about your blue question forms and thinking about your questions. Linda, given the limited capacity of service providers available for kids and families who already have coverage, how do you see the ACA expanding capacity for this very challenged jail population?
Let me just begin by saying, you know, we have, I think, pockets of excellence throughout this country right now. And some people in this audience are responsible for those pockets of really excellence, where there is collaboration between primary care, substance use, and mental health, connections to the criminal justice system. But I think the thing the reform legislation does is it tries to take pockets of excellence and make it a widespread way of dealing with people. So that's the wonderful opportunity we have. In some ways, we got what many of us have advocated for years. We got real integration. I mean, this bill is full of opportunities for integration. I think, you know, your comments about health centers working with community providers, I mean, the opportunities for bi-directional care in both ways, bringing primary care through health centers into behavioral health organizations, and then for behavioral health organizations to be working in federally qualified centers as well as ambulatory practices are enormous. And I think we're going to see that. I think the real sea change is about 15 to 16 million people having Medicaid insurance. And I think that creates capacity, because what is capacity? Capacity is taking advantage of opportunity, right? People now have an insurance card, and if we're smart, decent rates will go along with it, right? And Medicaid managed care will apply in terms of parity. And so people will be able to get the full array of services they need, from case management to outpatient clinic-based treatment, to assertive community treatment, the things that are clinically indicated, they'll now be able to get. And that will create opportunities for organizations that currently exist, as well as those that will come into existence to meet that need. So I think that's one of the sea changes. I think when you have to bill in order to get paid and you have to have volume, you have to create capacity. And I think in some ways, some organizations are wildly inefficient right now. We grew up in a very different kind of system, and I think the work that NIATEX has done, the work that the National Council has done around access redesign has showed us that some organizations might as well be closed Mondays and Fridays because they're hardly seeing anybody. I think now we're going to have the ability, and if you're a smart CEO, you're going to be looking at your productivity, and you're only going to be able to stay open if you have volume. And again, we have pockets of excellence already doing that. Now it's got to become much more widespread. In one of our projects where we've been working with about 73 organizations across this country who provide mental health and addiction services, they've been able to increase their revenue by $200,000. They've been able to do same-day open access. If we're going to be part of medical homes, right, you can't say to your partner, your healthcare partner, yeah, we're here, we'll see somebody, and we have a slot available in 6 weeks. I mean, that isn't the way the healthcare system is going to evolve. Working evenings, working weekends are things we're going to have to do. I think those are really our challenges internally. I just want to add one more thing. We also have opportunities in the Act around workforce. There is a huge amount of money under the National Health Service Corps for loan forgiveness, and it is also targeted to behavioral health. And people, certainly our members, are increasingly taking advantage of that. There's going to be more money in that. And I think we have a future around attracting people into healthcare generally and into behavioral health specifically. I think for people currently working and for people in graduate schools of psychology and social work and nursing who are interested in behavioral health as a future, we've got to look at things like standardized curriculums, making them part of the schools, making part of the accrediting exams. That's the work we have ahead. But we also have those opportunities, and I think this law really moves that along.